Hello. I just want to talk about the subject of antimicrobial resistance, or the resistance to antibiotics, and the role of corporations and the public in this area. I'm Hilary Thomas. I'm a partner at PA Consulting and Chief Medical Advisor. I'm actually an oncologist by background. So there are four aspects I want to cover. First of all, the current situation. Secondly, the barriers to awareness. And then the implications of all of this to business models and why this is currently a failed business model. And then what the role of companies and members of the public is in moving us forward. The reality is that this is a slow burn. It's a public health crisis that has the potential to kill 700,000 people every year. So whilst that total of deaths is not near the level of deaths we've seen with the pandemic, it is a much more chronic problem that has been coming upon us very slowly, to the point that it's almost as if we haven't really noticed. The United Nations Ad Hoc Interagency Coordinating Group on Antimicrobial Resistance projects that it could be killing 10 million people a year by the year 2050, which is really a horrific statistic. So it's vital that we reduce the unnecessary use of antibiotics and slow its progression. Sadly, the development of antibiotics by corporations has stagnated in recent decades. In fact, since 2000, only 15 new antibiotics have been approved, and only 4 of those are novel, meaning that the other 11 are actually just variations on existing antibiotics. And so they don't give us a particularly long period of benefit and value. We need more novel antibiotics and more alternative strategies as well. Many people don't understand antimicrobial resistance or what it might mean to them on a day-to-day basis. For example, you might think that when I get an infection, perhaps it will be resistant to an antibiotic, but someone will find an alternative. It might be a bit of a nuisance, but ultimately I'll be able to receive something that's effective, which isn't actually the case. For example, the most common urine infections in Italy have about 90% resistance to the main type of antibiotic being used. That could mean that if you contract a urine infection, it doesn't become just a nuisance that you have antibiotics for, it becomes a reason to go into hospital. It could have an impact on your kidneys. It could have an impact on your general health and well-being. And for some people, and we're talking about tens of thousands of people globally, it might mean that ultimately you die from that infection. So it's really, not just about individual immunity to antibiotics. It's about whole strains of bacteria affecting large numbers of people being resistant to antibiotics. And when only 10% of these types of infections are sensitive, it means 90% of the people who develop them are likely to have serious problems. So as a result of this lack of awareness of the implications, we also see rather a lack of urgency. And until this actually affects you personally or a member of your family, you're not likely to become educated. There are also significant implications for business models. What do I mean by that? Normally, if you have a pill for a treatment, then every pill that you take or every injection that you receive or every treatment prescribed by a doctor results in a payment to a pharmaceutical company. That pays for research and development, which is a significant cost, and it also pays for marketing, for ways of making sure that you get access to that treatment and ways of ensuring that that treatment is given in a way that is as patient-centric as possible and that engages the healthcare professional. The difference with antibiotics is actually we don't want you to take an antibiotic. We want you to stay infection-free so that the limited armamentarium that we have in this space is not being used up. So we have a drug that is only paid for when it's used at the moment, where we don't want you to use it. That doesn't make sense for the pharmaceutical industry. In fact, it's counter to very many business models, because we're talking about needing these drugs very badly, but there not being a mechanism to pay for their research and development. So we need a model that actually pays people not to use a drug. The British government has been one of the first to move into this area and has moved to what has been called outcomes-based payments for antibiotics. This means that actually, if you look at a population level, not needing to use the antibiotic will result in payment to a pharmaceutical company so that they can then use that money to develop new antibiotics and pay for antibiotic research. But it's a very unusual business model. It's almost an insurance-based approach, whereby we insure against the development of antibiotic resistance. We ensure that the valued resource of unusual antibiotics that are effective in extremis, when the patient has not really responded to anything else, is available, but in a locked cabinet. One way of looking at this might be with social impact bonds. Certainly in some research I was involved in a few years ago, we talked to some of the major banks about how they might support this kind of research, where people were paying for bonds that would invest in research and research platforms, but not be paying for every item that's used. So you could argue that a single dose of a very expensive antibiotic, which currently would cost in the order of hundreds of pounds, needs to actually be worth tens of thousands or even hundreds of thousands of pounds if you compare that with treatments for cancer, which genuinely do cost hundreds of thousands of pounds per patient. But the antibiotic sales model has grown up over decades, where actually in most cases these treatments are generic and very cheap, and so the barrier to using them is very small. Another aspect is that in many countries, in fact all countries, but some being greater offenders than others, antibiotics are used very freely in veterinary medicine. So the level of antibiotic that's actually circulating in the water in some countries is enough to start causing low levels of antibiotic resistance. The UK again has been in the vanguard under the leadership of Dame Sally Davis, the sponsorship of the former Prime Minister David Cameron and Lord O'Neill, to really make sure that the world is starting to develop an approach to this, and the UK has been in the vanguard. We have put safeguards in place, we have changed the way we use antibiotics in veterinary care so that we use them less, which is really important, but we also need to incentivize more development. And I think that's where corporations come in. This is perhaps a way we should be using sustainable development goals. We should be thinking in terms of the corporate social responsibility of organizations to think about how we might fund the development of new antibiotics, because we will need them in the future, albeit we will want to use them carefully so that we don't create more resistance to the newer ones that we have. And that means we need new research platforms. Perhaps a good analogy to this is the development of vaccines for the COVID-19 pandemic. Before the pandemic, in fact, only 2 to 3 months before the pandemic really hit the UK, I had the privilege to hear the chief executive of Moderna speak at a public forum where they genuinely thought that their future was linked to an mRNA vaccine for a virus called cytomegalovirus. They had no idea what was about to hit them, and that actually it would be an mRNA vaccine for COVID that would become their most important product. We know from the Pfizer-BioNTech success that mRNA vaccines are now here to stay. And whilst they aren't at the moment able to be delivered around the world because they need to be kept at very low temperatures, ultimately we're likely to achieve a point where they replace existing models of vaccines. And they have several advantages in that respect in terms of their efficacy. We need new platforms comparable to the mRNA platform in vaccines for the development of antibiotics, so that we're not just modifying many of the historical existing antibiotics, such as penicillin and cephalosporins. So that's where you come in thinking about your role on a day-to-day basis, whether it's as your representative of your own organisation or whether it's you as an individual member of the public. We need to support the education of the public in relation to antimicrobial resistance and create that sense of urgency. This is about really informing yourself when you go to the doctor with what you think is an infection about whether actually an antibiotic is the right thing. If you have a viral infection, then actually antibiotics aren't suitable. But we've created an expectation that people often leave the GP surgery with a prescription in their hands rather than some advice about what they should do. We need to create a world where people expect to be tested as to whether they have a bacterial infection before the antibiotics are started, which means we don't have to start an antibiotic as soon as we suspect a urinary infection. There are other things we can do. We can change the pH of the urine. We can encourage people to drink things like cranberry juice until we wait and prove that there is actually an infection that's a problem. Many people, particularly women, have bacteria in their urine but actually don't have any white cells. So the body isn't producing a response to those bacteria. And as long as you're kept an eye on and your renal function is monitored and we know that you're well, it may not be appropriate to use antibiotics because no sooner has the course of antibiotics finished, but within days, another infection may be present. Now, clearly that may be different in somebody who's become acutely confused and has a temperature, who's clearly sick with an infection. But we need to preserve those antibiotics for that situation, not just for somebody where we happen to do a routine test and don't wait, firstly, to prove what the bug is, and secondly, what its sensitivities are. Just prescribing any antibiotic, in the case I gave you earlier in Italy with Klebsiella infections, if you have a 90% chance of antibiotic resistance, then your problem is you're just going to increase that percentage even higher. So we need to reduce the pressure on doctors to prescribe antibiotics and the public's expectation of them so that we do conserve them for situations where they're really needed. And we also need to think about how we might fund new platforms and new approaches to address what is currently a failed business model. I talked about different bonds, social impact bonds. I talked about funding through foundations, through charitable support, through government, as the government have in the UK with the outcomes-based approach. But there are also possibilities of learning from other industries. If we think about the energy industry, given our ambitions to achieve net zero and the climate change issues that we all face, we want a world in which we're discouraged from using electricity and gas, a world where we think about using renewable energy or avoiding the use of energy. Even if you think about the approach to a circular economy with plastics, there are examples of incentivizing people not to use more. And our historical approach as a consumerist society needs to be addressed. And I think that needs all of us to work together, given the potential risks to life and the costs to the global economy over time. If you have any questions about that, then please contact me on the following email address. Thank you very much.